Hi, it's Dr. James. Wanted to go over some effects of an at-risk pregnancy on the newborn. This should be a little bit of a review for you, but I wanted to bring about some important points that you need to be aware of in case you see it again. The Silverman-Anderson Index is one that some of us use to assess respiratory distress syndrome in a baby, and that's as a result of lung immaturity or a lack of surfactant. Sometimes we even see this if a baby is born late preterm, which is considered at 37 weeks. It can also occur with transient tachypnea of the newborn. That's when a baby is in transition and they're trying to get their respiratory system going as it should, and they have tachypnea. Or it could also be a result of GBS or positive group beta strep. And this is a chart you can look at. The zero score is whenever respirations look just as they should, it's all synchronized, no retractions, no nasal flaring. But a score of 1 is whenever respirations are just lagging a little bit, or you see retractions just a little bit of nasal flaring. But then a score of 2 if you can hear a grunt and marked retractions where the chest is like sucking in the intercostal spaces or at the xiphoid process. The NAS score stands for Neonatal Abstinence Syndrome, and this is when we have a baby that's withdrawing from substance abuse, usually opioids, barbiturates, SSRIs or benzodiazepine, sometimes even caffeine, alcohol, and even nicotine. This is a chart that you can look at for the different scores based on the child's signs and symptoms, any kind of vasomotor respiratory problems or GI disturbances, and we give it a score. How they act in the AM and how they act in the PM. Withdrawal acronym that we might use to help us determine what's going on. W stands for wakefulness. They sleep less than 3 hours after a feeding. A, anxiety, irritability. T stands for temperature variation or tachycardia, or are they having tremors? H for hyperactivity, a high-pitched persistent cry, hyperreflexia or hypertonus, that should be a T there. D for diarrhea, diaphoresis, or disorganized suck. They will suck rigorously because they're trying to comfort themselves. R for respiratory distress, a rub mark or rhinorrhea. A for apneic attacks, autonomic dysfunction. W for weight loss or failure to gain weight. A for alkalosis, which is respiratory alkalosis in this situation. And L for lacrimation. Signs: they may have fever, frequent yawning, mottled skin, sweating, frequent sneezing, nasal flaring, tachypnea, which is over 60 breaths a minute, apnea. They do not feed well, but they have frantic sucking or a rooting reflex, loose watery stools, and many times regurgitation or projectile vomiting. Now, this is if they're going through withdrawal because they're not getting whatever substance mother had anymore. This picture, I enlarged it so you could see it. Disturbed sleep patterns, of course, irritability. We wrap them tightly to try to snuggle them because they have a difficult time comforting. Constant movement, a shrill, high-pitched cry. It's a type of cry that's totally different from what you're accustomed to a normal baby cry. Tremors, vomiting, tachypnea, diarrhea, and of course hyperreflexia. So substances can be abused. This is a really good chart for you to read over. It gives you a good digest of alcohol, tobacco, nicotine, what it can cause, and the nursing implications, as well as marijuana. Methamphetamines are really ugly. Lots of problems with the fetus, similar to cocaine use. And because mother is usually malnourished when she's on meth, there's lots of issues that can happen with the baby. Um, the baby will be dysphoric, agitated, jittery, poor weight gain, doesn't sleep good, poor feeding, frantic, fist sucking, a high pitched cry, respiratory distress, have frequent infections, and we still don't know what the long term effects are. Cocaine is another ugly one for a baby to have to withdraw from. Whenever they are in withdrawals, many times we will have to start a drip with some type of drug, very, very small amounts, but to help them through their withdrawal. The newborn of a diabetic mother, as we talked about before, macrosomia, they have an increased risk for shoulder dystocia because they're so big, and so then this puts mom at risk for traumatic birth injury. The baby could also be injured, can also suffer from birth asphyxia. There is a high risk for a newborn hypoglycemia, hypomagnesemia, polycythemia, and electrolyte disturbances. And why is that? Increased maternal risk for a surgical birth, a hemorrhage, and an infection, and birth canal lacerations. The baby is going to have an increased risk for developing type 2 diabetes later in life. And mother also will have an increased risk. If she's gestational, she'll have an increased risk of developing type 2. The baby has a higher weight and accumulation of fat in childhood and a higher rate of obesity. For RDS, this is most commonly breathing normally at birth, but then they start developing a labored grunting respiration and coughing and a very hoarse cry within a few hours, and then start showing chest retractions. Insulin dependent moms with vascular disease and they have poor intrauterine perfusion. And this is going to increase the production of steroids, so they're going to have a accelerated lung maturation. So this is babies born to insulin dependent mothers who have vascular disease. Hypoglycemia, if mom has hypoglycemia, the baby's going to have low blood glucose, and this is very problematic for obvious reasons. If mom has hypocalcemia and hypomagnesemia, the baby is at risk for a prolonged delay in parathyroid hormone production and may have cardiac dysrhythmias. Polycythemia, of course, the venous hematocrit is greater than 65% in the newborn. So the blood is increased in viscosity, so there's poor blood flow, and that predisposes the newborn to decrease oxygenation. Hyperbilirubinemia, if it's untreated, there's high levels of unconjugated bilirubin, and this can lead to kernicterus, which is the most severe type of hyperbilirubinemia, and it causes neurologic syndrome, irreversible brain damage, that can lead to cerebral palsy, hearing loss, and mental retardation. Congenital anomalies, the most common ones, and we don't talk a whole lot about high risk because this is over what this course, way above what this course is intended, but the most common congenitals are coarctation of aorta, atrial and ventral septal defects, transposition of the great vessels, sacral agenesis, hip and joint malformations, anencephaly, spina bifida, caudal dysplasia, and hydrocephalus. And this is from a diabetic mother. It accounts for 30 to 50% of the perinatal deaths, and those who do survive could have some of these issues. That's why we have talked about before, mothers who are diabetic have 3 times the usual incidence of having a baby with congenital problems. So, lab results, we need to focus on early detection: hypoglycemia, hypocalcemia, hypomagnesemia, dehydration, jaundice if it's greater than 12 milligrams per deciliter in a term, and polycythemia. What is the baseline? So we need to know these things so that we know if we're having a problem. Why are we worried about hypocalcemia? Because we could have it could be a result of a birth injury, and it is possibly going to be a delay in a parathyroid hormone production once the baby is delivered. Why are we worried about hypermagnesemia? It parallels calcium, so we have to have a balance between the two, and so we always suspect this whenever we have hypocalcemia, and especially if it's not responsive whenever we administer calcium replacements. Red blood cell breakdown leads to polycythemia. So they'll have an increased hematocrit, and the liver is very immature, or they've suffered birth trauma. So they can have hyperbilirubinemia in the first 24 hours, and this is pathologic if it happens within the first 24, or if it's after 24 hours of birth, it's called physiologic hyperbilirubinemia. Birth trauma with a diabetic mom because of macrosomia. They're large for gestational age. What about with small for gestational age? Do you think there could be birth trauma associated there too? Sure. If the baby has to, if we have to use forceps, if it's a precipitous birth, but for sure with macrosomia, we have to be very careful because there can be trauma. So that's all with the diabetic mother and neonatal abstinence syndrome that you would need to make sure you're familiar with. Any questions, please let me know.